Hello and welcome to COPD Wellness. In this episode, Russell chats to Dr. Stephen Phinney, a physician-scientist who has spent 35 years studying diet, exercise, fatty acids and inflammation. He has held academic positions at the universities of Vermont, Minnesota and California at Davis, and leadership positions at Monsanto, Galileo Laboratories and Efficas. He received his MD from Stanford University, PhD in nutritional biochemistry from MIT, and did postdoctoral research at Harvard. Currently, Dr. Phinney is the Chief Medical Officer and co-founder of Virta Health, a specialty medical clinic that reverses type 2 diabetes safely and sustainably without the risks, costs, or side effects of medication or surgery. Dr. Phinney's decades of experience in ketogenic diets, coupled with his experience as a medical doctor treating respiratory patients, make him an ideal guest for the COPD Wellness podcast. So sit back and enjoy part one of our chat with Dr. Stephen Phinney.
Dr. Phinney, welcome to the show.
Hello.
Hey, how are you?
I'm well. How are you?
I'm very good, thanks. Today, I just want to talk to you, I guess, basically about ketogenic diets and how they can apply to, in particular, respiratory diseases. I don't know if you remember last year when you were in Brisbane, I asked you a question about the effects that ketogenic diet could have on respiratory diseases.
I actually had the opportunity as a physician in hospital to deal with patients who were on a ventilator because of pulmonary disease involving CO2 retention. And because they couldn't be weaned from the ventilator, they were feeding them with a feeding tube and they were feeding a high carbohydrate diet. And my thought was, why don't we switch to a low carb diet, which would produce a lot less carbon dioxide per unit of energy consumed, which means they'd make less CO2, which means it would make it easier theoretically to get them off the ventilator. So my thought was simply the CO2 reduction, but the response in 3 of the 4 people, and by the way, once somebody, as we call them, ventilator dependent, that's a downhill slope. It's rarely do you if you don't cure an infection and get somebody off the ventilator within 3 to 5 days, rarely do you get them any stronger because their respiratory muscles are atrophy. And so when we put them on the high fat, very low carbohydrate tube feeding, within 2 to 3 days, the responses were dramatic. And the pulmonary doctors were amazed. But, that never went anywhere.
Well, I guess that's how when I talked to you last year, that's how I got so interested. So from my point of view, I'm a COPD patient. To give you some background and severity, my FEV1 hovers as a percentage hovers between 22 and 30%. I don't have a huge issue with CO2 retention in day-to-day life. However, I need oxygen when I travel by air and also when I'm at altitude. And also sometimes when I exercise, I sometimes use a backpack oxygen unit. So when you talked to me about this last year, I went away and did a bit of research, PubMed, like a lot of people do, I guess. And that's where I found a study dating back to 2003, I believe, where they took a group of COPD patients and they fed them a high-fat, lower carbohydrate supplement. And all patients significantly improved their pulmonary function. And I sort of figured, I wonder why this isn't standard practice these days. Can you shed any light on that?
There is a concept, and I call it a concept, that when you use a biochemistry chart of how much ATP, that's energy, cellular energy, can you get from a liter of oxygen by burning carbohydrate or burning fat, on paper, the calculation is you get 8% more energy burning fat per liter of oxygen than you do burning carbohydrate from oxygen you do from burning fat. And so theoretically, somebody who's got limited ability to get oxygen into the body would do better burning a high carbohydrate diet. And that's been around since the 1920s probably, or 50s somewhere, back long ago. And it's taught to everybody in terms of pulmonary medicine. But there's something not right about that. In that I've done exercise studies with people on a ketogenic diet, and we measure their oxygen consumption, and they exercise on either a low carbohydrate diet or on a high carbohydrate diet. We don't see any significant difference between the oxygen cost of exercise. So if you put out the same number of watts of power on a stationary cycle, and you use the same amount of oxygen, we would see an 8% difference, and it's not there. But I have been told by world famous exercise physiologists in debates within the last year that my concept of using a ketogenic diet for sports to enhance endurance sports performance, that it's fatally flawed because of this theoretical difference. And there was some data published it was about the 1950s, using very old technology, not necessarily flawed, but old technology about oxygen, in measuring oxygen used during exercise, that saw a difference in people on a high fat versus a high carbohydrate fueling regimen. But those are studies that were done without much adaptation. We didn't give people time to go through the keto adaptation process. I would say we, but they. So it's basically a textbook concept that has a life of its own, independent of the data. And as you're probably aware, in ultra endurance sport now, many world records and course records are being set by low carbohydrate athletes. So there's a guy by the name of Zach Bitter, who's a ultra runner here in the United States, and Zach set the U.S. record for 100 miles run on a track. If you could actually believe somebody running 100 miles on a 400-meter track, and he set the U.S. record at let's say 11 hours and 46 minutes to run 100 miles on a ketogenic diet. And then one of our local very extreme races over the mountains called the Western States Endurance Run from here in California, from Lake Tahoe over the Sierra Mountains, 100 miles on trails. And a guy named Tim Olson not only won it twice, but he set the all-time course record using a ketogenic fueling regimen. And some of that altitude there is up as high as, I have to put it in meters, 2,500 meters. So clearly there is no obvious hobbling effect in terms of the net effect on the human body, but it's hard to get past this concept.
It is. Just rewinding a little bit, because a lot of the audience of this podcast will be either respiratory patients or respiratory professionals, and many of them may actually not know what a ketogenic diet is. So could you give us your explanation, since you are probably the most qualified to do that?
There are many strategies to achieve what we call ketosis or nutritional ketosis. And the reason, and I actually coined the term nutritional ketosis in a publication back in 1980, because what doctors are taught about ketones is that they are toxic products that build up in the bloodstream of people who have type 1 diabetes when they aren't getting enough insulin. And that's called ketoacidosis. And that's levels numerically in the 15 to 30 range. And when we talk about nutritional ketosis, we talk about the 1 to 3 range. So it's a tenfold difference between the severe, very life-threatening condition, ketoacidosis, nutritional ketosis. But if you have buttered toast and juice for breakfast, typically a person eating a high carbohydrate diet will have values of 0.1. So 0.1, 1, 10. Nutritional ketosis is in the 1 to 3 range. And the way somebody achieves that is by limiting most, not all, dietary carbohydrates, certainly the concentrated ones in terms of bread, rice, pasta, high sugar fruits, and starchy vegetables. And what that leaves a person is moderate protein intake, with the natural fats that occur in whatever the sources of the protein are, whether it be meat, poultry, fish, eggs, cheese, a reasonable amount of non-starchy vegetables, so cooked greens, green beans, cauliflower, broccoli, onions, so non-starchy vegetables as a significant part of the volume of one's diet, but the majority of one's calories will come from fat. That's a little scary for most people, but that fat can come from either the animal fats and the protein sources, from vegetable sources of fat, particularly olive oil, monounsaturated sources from olive oil, avocado, and one can use grain source high monounsaturated oils. They now have safflower, sunflower, and canola oils, which are very high in monounsaturates. And the reason we like the monounsaturates is they're very easy for the body to burn. And on a high-fat diet, the majority of what you burn will come from fat. Mm-hmm. So those are the dietary approaches, and that's what I prefer to use. This is not, for me and for my patients, not a made with processed or isolated chemicals. This is just a real food diet, things one buys in the grocery store. Now, there are other strategies. One of them is, rather than restricting carbs so much all the time, some people restrict carbs for just a few days at a time, and oftentimes restrict carbs and restrict calories in the interest of losing some weight. And that's called intermittent fasting. And there are multiple different strategies for that, where in a day or two of eating very little in the way of carbs, one will achieve these 1 to 3 ketone values, but it's transient because the next day when one eats carbs, it goes back down. But that puts one into an in and out state, and some people advocate that, and there's animal studies that say that that can be a beneficial state. And then the last way to get ketones in this range is to actually consume ketones as a isolated chemical, usually in a beverage, but they can be put into foods. Mm-hmm. And so one can eat ketones to make the blood levels go up. But we can come back to talking about the rationale and the cost of that as a strategy rather than eating a diet that's restricted in carbs. But as I say, my bias as somebody who has done this personally for more than a decade and have worked with patients who have chronic conditions like type 2 diabetes, this is not something we do for a week or a month. If you get somebody who is on multiple medications for diabetes and then you put them on a ketogenic diet, they find it much more easily to lose the weight that's oftentimes associated with type 2 diabetes, and their medication use is either completely eliminated or markedly reduced, and that's then something people want to follow for decades. And if you can do that with what you just put into your cart in the grocery store, I think that's far better than using isolated chemicals. Yeah. But there is a rationale for the other side. We can talk about that.
Yeah, I mean, from my point of view, I've been using the ketogenic diet now for just over 12 months, and I use it the way you've just prescribed it, using whole foods, and I've had a lot of benefits from it. My last pulmonary function tests, I had a 38% improvement in my FEV1, so that was one noticeable difference. Also, my inflammation markers as far as CRP has gone from quite high to my last reading was 2. So there have been a number of benefits for me as a respiratory patient. But I guess a lot of the kickback I get is the whole fat conversation. And many people think if they have this quantity of fat, it's going to give them heart disease or something like that. But that's not the case, is it?
Let's say that it hasn't been adequately studied to quell the concerns of our critics. Mm. Part of the reasons it hasn't been studied is our critics, the people who control the purse strings for research money, have made it very difficult to do this research. As you're probably aware, I teamed up with a remarkable young researcher named Dr. Jeff Volek, who's a PhD in exercise physiology and a registered dietitian. And he and I have pursued a number of studies looking at some of the things you mentioned in terms of disease risk, particularly around inflammation biomarkers, diabetes, but also blood lipids and blood fatty acids. And so when one eats a high-fat diet, the concern is, and again, a soundbite we oftentimes hear is, you are what you eat. And so people think if they eat a lot of saturated fat, their body's going to be kind of infused with saturated fat, and that's going to do them great harm. Jeff and I like to say, no, you are what you save from what you eat. Mm-hmm. So in our research, one of the most profound things we've demonstrated in untrained people, but also in highly trained athletes, is that when one takes, for instance, a highly trained athlete, and again, if somebody's trained as an ultra marathon runner, the training is thought to optimize their body's ability to mobilize and burn fat. Yes, they consume carbohydrate, but they want to get as much calories as they can from fat in an endurance event because the body's stores of carbohydrate are relatively limited. So when we take one of those highly trained athletes and we transition them to a ketogenic diet, not for a few days or a few weeks, but for months or more, and then measure their body's ability to burn fat at the same exercise intensity, we double the body's ability to oxidize fat for fuel. Now think of that as unplugging the drain. And the drain is, where do the saturated fats go when we eat them? If you double the body's ability to burn saturated fat and total fat, then fat is less likely to build up. And when we actually measure the levels of saturated fat in a person's blood who's eating a high-fat diet, and we're not restricting their saturated fat intake, we're letting them eat the eggs and the cheese and the butter, we actually see lower levels of saturated fat in the blood with people eating a high-fat diet. Now, we're the first people to do this type of study. We've done it now in 3 different settings, in 3 different groups of people, and we get the very consistent result. Those things are published in the medical literature. So saturated fats don't build up. And there are studies that show that when you look at people at a point in time and then follow them for a decade, the saturated fat level in the blood is a very, we say, robust or effective predictor of heart disease, diabetes, and mortality. And so, yes, saturated fats in the blood are very important. But when you train the body to burn saturated fat more than twice as fast, it doesn't accumulate and it's not a risk. So in the context of as we say, well-formulated ketogenic diet, that is the right amount of protein, not too much, the majority of calories coming from fat, avoiding the concentrated polyunsaturates in dietary fat intake. And again, that's important because, as you know, polyunsaturates of the omega-6 class can promote inflammation, and they aren't really good fuels for the body. So when we give the body monounsaturates and saturates and allow it to double its rate of saturated fat use, the body's fat economy is actually optimized. And then the last issue is the classic measurements of coronary disease risk around cholesterol. So the so-called good cholesterol, HDL cholesterol, and the bad cholesterol, which is called LDL. Those concepts have taken a beating of late because it turns out that it's not that simple. It's not just good and bad cholesterol, but the LDL category, for instance, is a range of particle sizes, and it's only the very small particles that are dangerous, and the larger LDL particles aren't dangerous. And again, when somebody goes onto a well-formulated ketogenic diet, those small particles are markedly reduced. And we have, again, done that research with what people adapted to a ketogenic diet. Again, long enough for this adaptation process to occur so the body has achieved a new steady state, if you will. Then good cholesterol, HDL, goes up, and if the LDL total cholesterol doesn't go down, the small dense LDL goes way down, indicating a reduction in risk. So, it's a long-winded answer, but it's a very complex thing. It doesn't lend itself to sound bites. But a high-fat diet, including one that contains considerable, not emphasizing saturated fat, but not avoiding saturated fat, actually shows across-the-board benefits in terms of biomarkers of inflammation, levels of saturated fat in the blood, and the distribution of cholesterol between the so-called good and bad fractions. So from a research point of view, it's pretty much case closed. In terms of people accepting that in the medical community, we're seeing a lot of positive change in people's opinion, viewpoints now over even just 3 to 5 years ago. So we think we're on the cusp of change here, and hopefully this will become less of an issue.
So for a respiratory patient who want to explore a ketogenic diet, their best approach would be to go through a nutritionist or dietitian who is well versed in the ketogenic diet. And are there many of those sort of dietitians around?
More and more we're seeing nutritionists and dietitians who have experience with this, and it takes a fair amount of experience. There are very few education programs to teach people, at the professional level how to do this. As you're aware, Dr. Rod Taylor and Low Carb Down Under has done a remarkable job of bringing these concepts to Australia and New Zealand, and to bring professionals into a kind of a association of where they can share information and share experience. So you're probably better off in Australia than we are in North America. But again, we're making progress with this, and there are a number of meetings that are being held for interested people, including healthcare professionals, to help them understand these concepts. But the first thing that I do have to mention, that for a respiratory patient or somebody with other serious chronic illness, and again, my focus and the focus of the company I'm now working with is type 2 diabetes. When somebody adopts a ketogenic diet, the benefits don't occur slowly. Some of them do, but some of them happen very promptly. And if somebody has hypertension and is taking one or more medications for high blood pressure, if they have type 2 diabetes, in particular, adopting a ketogenic diet oftentimes dramatically improves that condition such that the medications have to be reduced or stopped promptly. If they're not, with hypertension, a person's blood pressure may go too low and a person may pass out or collapse. In terms of type 2 diabetes, if they're on medications to lower blood sugar and you take away most of the carbs, within a few days, we normally have to cut medications either way down or even stop them. And that takes the active participation of one's doctor, one's physician, as part of that team. And that is an impediment to doing this safely. So I do want to be cautious and say, don't just try this and 2 weeks later go to your doctor and say, hey, look, I feel better, I function better. It really has to have a physician involvement. And that's the impediment that we're struggling with, is finding a way to alert physicians to this and train them in the safe use of this to reverse chronic serious diseases like type 2 diabetes.
It's interesting. I went to a conference a few months ago, a respiratory conference, and it was about new technologies and treatments in COPD, and they talked about multidisciplinary teams and went around the circle of your general practitioner, your respiratory specialist, your respiratory therapist, physiotherapist, and nutrition. So they talked about each profession, except they didn't talk about nutrition, which I thought was quite interesting. They included in their multidisciplinary team, but they actually don't discuss how it fits in. And I wonder whether that is part of the problem, is it's not discussed and whether it's not taken seriously.
Up until now, the recommendations for nutrition have been mostly focused around heart disease risk and fat reduction and saturated fat reduction. And that's now clearly a failed paradigm. The low-fat diet in study after study has not proven to be beneficial either for heart disease or for type 2 diabetes. And the more intensively you push that to a patient, the poorer the outcomes. People become discouraged. So physicians, as a general rule, say, well, we recommend diet, but it really rarely has any benefit. So we go right to medication. And so we really have pharmaceuticalized the management of multiple different chronic conditions because our diet message was flawed. As you are aware, again, I'm a founder of a company that is not a low carbohydrate diet company. It's not a dietary product company. We don't sell products. It's basically a digital online medical clinic to educate and support people to do a well-formulated ketogenic diet. And I'm doing this with an entrepreneur in the Silicon Valley who's a former very successful internet company entrepreneur who himself, as a world-class athlete, developed pre-diabetes because he was eating so much carbohydrate. And so we are developing a way to do this in pure online interaction with the patient. And so it's a full medical clinic. We have our own physicians. We have our own highly trained health coaches. They don't have to be dietitians. And so the patient has access to our clinic through a smartphone or through a computer, through a tablet continuously. And so it's continuous remote care that can be delivered directly to the individual. And then we keep their primary care physician in the loop, if you will, so that they're informed about what we and the patient are doing. But by doing that, we are able to provide the full range of information and support. We do biometric monitoring. The patients have an electronic scale that uploads when they stand on it to weigh themselves. It uploads directly into our app. They have for diabetes, they have a blood glucose meter that's done with a finger stick glucose measurement that they can do up to multiple times per day, and we can track that on a continuous basis. And then to track the nutritional ketosis, we use a separate test strip for the glucose meter that actually directly measures blood ketones, which is really the only accurate way of measuring ketones we currently have. And in that way, we can basically do the intensive, careful monitoring that it takes to manage people in the early phases of adapting to a ketogenic diet. That's really the only way we can see how we will scale this. We can't change how medicine is practiced from the top down. And so we can basically bring this into the marketplace as a bottom-up alternative clinical approach that provides the medical expertise and the monitoring necessary to do this safely.
And with this new company, it's Virta Health, I believe the name of it is. Is it just diabetes you're going to be looking at, or type 2 diabetes, or are there other diseases you're going to be trying to treat as well?
Oh, I'm an internal medicine doctor. I'd like to treat a lot of different diseases. I mean, there are a number of possible targets, but the epidemic of type 2 diabetes, in the United States, I think that statistic the prevalence has increased fourfold since 1970. We should be doing much better than that. So it's a major disease that's going to bankrupt our healthcare system. So our focus right now is on type 2, but there are many other candidate areas that we could go to. But as a company, if we don't focus, we potentially will kind of get lost in the weeds of trying to do too many things at once. But we do have, as you're probably aware, Russell, we're running a study in the central part of the United States in the state of Indiana, where we've recruited almost 500 people with either type 2 diabetes or pre-diabetes, and 80% of them are being treated with the low-carb dietary intervention, and 20% of them is a group of, we call them control population receiving usual care. And we're following, initially planned to do this for 2 years, and it's going so well, we've now extended it to anticipate to do it for 5 years. And the reason and by the way, this is not being funded by federal research dollars or money from foundations. This is being funded by the investors in our company because we think we can prove beyond any doubt that this is a very effective intervention delivered not just in the short term, but in the longer term. And we're now beginning to collect 2-year data from the subjects in our study. We published our early data from just the first 10 weeks, and we have a paper on our 1-year data that's currently in review by, in the peer-reviewed research journal arena to demonstrate the efficacy of this intervention. It's not an easy sell because, again, it's not what most doctors were trained to anticipate or to do. But we think that this is the way we can demonstrate really the therapeutic power of nutritional ketosis.
It's interesting because I know from my own experience or experience with other patients is that a lot of them are dealing with more than one disease, and certainly type 2 diabetes, rheumatoid arthritis are 2 very common diseases that patients are dealing with as well as COPD. So it would be interesting to see whether you come across those type of patients in your practice where they've got multiple diseases and whether the ketogenic diet will actually benefit a range of diseases that they have instead of just targeting one.
Yeah, and we are not ignoring that. It's not our focus, but as part of this study, we are monitoring sleep and the use of what's called CPAP, continuous airway positive pressure, for people who have obstructive airway disease. Sometimes they can't sleep because of they don't breathe when they fall asleep. And this is common in people with diabetes and obesity. And we're actually monitoring that through questionnaires and interviews with our patients. And I can't say anything about this because we haven't published the data yet. You know, we don't brag about results until they've been verified by the peer review process. But our patients tell us that oftentimes they have marked improvement in their airway disease initially when they go on the diet and then as they lose weight. So there are both two factors. There's the respiratory drive, what the brain perceives chemically that tells us we need to breathe, changes when you go on a ketogenic diet. And then for somebody with a lot of extra body weight in the upper part of their body, as they lose that excess adipose tissue, their respiratory function improves. And I can just tell you that I hope within 6 months or a year, we'll be able to share with you data at the 1 year time point showing marked improvement in particularly airway function during sleep.
I think a lot of people will be interested in that data when it comes out, that's for sure.
That was just the first part of our 2-part interview with Dr. Stephen Phinney. For more information on ketogenic diets, be sure to check out the articles on the COPD Athlete website, and you can find Russell on Facebook under COPD Athlete. Tune in next week to hear the second part of the interview with Dr. Stephen Phinney. Thanks for listening.
Bye for now.